All right, good afternoon, everybody. Once again, welcome Dr. Svante Berg with Stockholm Spine Center. How are you doing today?
I'm fine, and you?
I'm doing fantastic. Sunday afternoon for me. It's raining and pouring, thundering, so you may hear a little background noise from me, but let's get this moving for the ADR support group and education with Dr. Berg. Hey, Dr. Berg, we're going to talk with some general questions and divulge into some more of the higher end questions. Let me get to them right now. So how many ADR surgeries have you performed in your lifetime?
What was the name of it? Do you mean anterior disc replacement?
Correct.
Yeah, ADR. Okay. I've done almost 7,000 patients, and I've implanted between 12 and 13,000 implants of different brands.
And how many different brands have you implanted? And maybe you could go through the list real quick if you can recollect them all. I mean, you don't have to give the ones maybe you did a ones or two or do a little trial, but more of the ones that you thought, hey, this would work, and maybe some of the outcomes.
Yeah, I started out in the mid-90s with the Charité and the ProDisc, preferably the ProDisc, but I did some Charités too. I wasn't so pleased, so I did much more ProDisc than Charités. And then I did a randomized trial between posterior fusion compared to either Charité, Maverick, or ProDisc, because I didn't want it to be a brand study, more a mobility against stiffness study. So that's why I used 3 processes, and they were randomly signed up to persons, whether they were 1 or 2 segments. And after that, I, for a short while, used the processes called FlexiCore. And then I kept Maverick for a while. I went on to something called the Kineflex, also metal on metal, but 3-part device, more imitating mobility of a healthy disc. Then I both heard of and had 4 cases of reactions on the metal, 2 from Maverick and 2 from Kineflex, where the nanoparticles created a spinal stenosis to decompress and to fuse those patients so they wouldn't produce any more nanoparticles. And after that, how many processes is that? That is 5, I think. And after that, I went into Orbit. That is similar to the Kineflex, but it's peak on peak from Globus. The only difference is that it translates only anterior and forward, not sideways. And I would guess I started using that around 2011 or so. And then since a couple of years, I use processes that we call SAC, but it has another name in France. It's a viscoelastic processes. I started using that and did that for a while, parallel to the Orbit, and I couldn't see any disadvantages of this French prosthesis. On Swedish patients, I'm presently, if it's 1 or 2 segments to treat, randomized between Orbit and SAC to prove whether viscoelastic prosthesis, as I assume, is closer to healthy discs than mechanical ones. I still, also on Swedish patients, don't enroll everybody if they had a previous fusion or if it's more than 2 segments. I would they are out of the study, and then I use a SAC.
Have you ever, and this is more for our patients here in the United States that really would like to stay in the United States, have you ever tried the Activell by Ascula?
No. I know Rolando Garcia well, and he's tried it. I had dinner with him the other night. At the same time as he's pleased with it, he's keen on getting the SAC, and he was very careful with asking the French reps whether they're gonna do the ID study for it. So obviously he's interested, but he's the Activell guy in my mind.
Oh no, he helped produce a little bit. I mean, I think he put some of his own science and behind the product.
Yeah.
I know a few patients from here that went to him as well and got an active L. Okay, fantastic. And you do hybrids as well as straight ADR, correct?
Yeah, depends on the segments involved. It's always an advantage to do the surgery from front for musculature, for risks, for infections, for everything. And then I judge the segments one by one. Are they capable of hosting a total disc replacement, or would they rather be fused? That means that some patients end up with a hybrid. More patients end up with only disc prosthesis, but I'd say about a third of what I do also have a hybrid.
So when you're performing your procedure, do you preserve the anterior longitudinal ligament?
No.
Okay.
We did that in the mid-90s, and then we had very pessimistic checkups on what happened with those anterior ligaments that we cut out and carefully stitched back, and they went out on nothing. So it's not worth presenting that. For a while, I think it was Dr. Petin that developed a net to put there in place of the anterior ligament. But there were difficulties with that. You had to prepare much more to get position of the screws. And it's an issue. If we're going to settle with just mechanical prosthesis, then I think the patient might have a favor of having something put there, something that imitates the effect of the anterior ligament. But since most of the world is moving towards viscoelastic prosthesis, I think that question has sunk little under horizon.
Do you require a DEXA scan for new patients?
No, I don't require it, but sometimes I ask them to take it.
And why? What circumstances would make you ask them to take it?
First of all, if I have an impression from normal X-rays that there is thin bones, but that is a very dubious science since it depends a little on how the pictures are exposed. But if I have a lady with early climacterium, smoking, or being a smoker, and I would have it. If I had a male person, 60 years of age, not smoker, I know that he wouldn't have an osteoporosis. So it depends on age, sex, smoking habits, and my warning signs.
We've had some patients, that have gone to, several surgeons, and the answers are all over the place. Some require DEXA scan, and then some also do an intraoperative vertebroplasty. And that's something, have you ever done where you've got in there, saw soft bone, much softer than maybe you would notice, or and would you do that type of procedure?
I wouldn't put myself in the situation that I have to do it. I think you've chosen the wrong patient for this method. Looking back, I had 2 patients more than 20 years ago that had too weak bone structure for disc prosthesis. I didn't realize that at that time, and they had fairly early subsidence of the prosthesis. And that was due to my stupidity in 2 ways. I didn't see the problem from starters, and probably I didn't hang the prosthesis all the way to the anterior ring or to the PLL where the bone is strong. So it might be you shouldn't have subsidence with prosthesis. If you have that on a healthy person, then you put the prosthesis in the wrong place.
One of my moderators, and I'll give you an example. He is about 6'5".
And that is in centimeters?
He is, I think, 179. I could be wrong about that. He's probably about 2-3 inches taller than you. Probably a good 3 inches taller, because we met each other, and he has very large vertebral bodies, very large. So he had a 3-level done, L3 on down to S1, and his his prosthesis looked relatively small compared to his bone. And one of his levels, it subsided a little bit, and this is using a ZAC. Would you fear that he would have any issues with that?
Probably what would have happened, I guess he's not 179 if he's taller than me, maybe 199.
Maybe.
Or, yeah.
My conversion might be.
Yeah, I'm 189 myself. So I think Zach has the largest end plate of the competitors. That might be a problem for very small people, but
Sure.
they are developing one with a little smaller end plate now. But until we get that, I try to keep off persons that are below 158, 160 centimeters, and I don't know what that corresponds to in your strange measurement. But anyhow, I think I had a basketball player just recently that I did 2 segments on, and on such a person, the SAC prosthesis doesn't. I don't feel that it's that big anymore because the person in itself is very big. But even so, if you hang it posteriorly on the posterior ring, I think the forces, even from a big body, wouldn't necessarily have to give a subsidence. It might be that that prosthesis that subsided was a couple of millimeters too far forward from starters, or he's just unlucky. And then what happens, either it subsides so much so he will spontaneously fuse that segment, or if not, it will still be movable since there is no center of rotation or center of movement in that prosthesis. So it can still function even if you have some subsidence.
Yeah, I mean, I think that's the conclusion he's made, and that's what I've kind of told him as well. It's I think just a little bit of the end plate subsided, not much at all. And he said he did it by picking up his daughter, and that's when he kind of felt a change. I don't know if you could actually really feel that change doing something like that. And I'm not saying he's wrong, but you know, he's a big part of our group, and he's always very helpful. And I just thought this would be a good way to kind of give him a little help back and a little confidence on that, because I knew what the answer was, but obviously coming from you is going to send a whole lot of better mojo, I should say. Do you happen to use bone wax, to smooth out the irregularities in the end plates with your patients?
No. Bone wax is something that prevents bone ingrowth, so right. No.
Okay. Moving along. Let me see. Do you happen to use a adhesion barrier, or have you ever used adhesion barriers?
I've looked at it. Yeah, I've looked at it, but and I've discussed it with my friends, the access surgeons, and the frequency of coming back is so extremely low after anterior surgery, so it's not worthwhile the fiddling, putting it there. We'll get back if we need to anyhow.
Do you use a vascular surgeon?
Yeah. Yeah.
100% of the time?
Yep.
Okay.
I started doing A-lifts more than 30 years ago, and at that time regulations and things like that in Sweden admit me to work that way, and I had no disasters, but they had on other hospitals. And after that, the regulations were changed from about mid-90s, so you should have access to a vascular surgeon or access surgeon, even if not in the theater, so at least down the corridor. And since the hospital I always work in is rather small, I have to get him there, and if I've got him there, he might as well do something. So he's with me in the theater.
Okay. What is your approach to VTE?
VTE?
Yeah, venous
thrombosis?
Correct.
I always protect my patients on it. That is, during this day of surgery, you dilute people. You always do that. So their blood is thinner, just to hold up pressure during anesthesia and so on. But from the day after, I give them something called fragmine, that is anti-thrombotic, they take it for 10 days. If they have a history of earlier thrombosis, they'll take it for 4 or 6 weeks. I had one ALIF case in the early 90s that developed a thrombosis in her calf, and everything else was perfect with that young girl. She is also a doctor nowadays, but that is so irritating because she has to have a certain sock on when she flies, even if it's so many years ago, and it's so totally unnecessary. So that's, after that, I always use it.
Okay. What is your usual post-op pain control? I mean, what do you do for the first few days once a person leaves the theater?
Well, the only pain that the patient is supposed to have afterwards is from the wound in the abdomen. And we treat that with paracetamol and opioids in combination.
Okay. So, for example, and I know we've talked about this in depth, but say there is an issue with a patient, they need to come back for whatever reason. Maybe they're still having pain and something may have been missed or something like that. Is there a warranty, I should say, and a warranty is kind of a strange word to use, that they can come back for a period of time? Some surgeons, year out, they'll cover maybe we know the ZACs don't have any failures at this point, but say something did happen with a ZAC, would that be covered under your hospital?
Yeah, we never charge for that. It's not very common with anterior surgery, but since at our clinic we do a lot of other surgeries too, and we do degenerative deformities and this and that, where these problems are fairly frequent. And we never, for the Swedish system, we are not allowed to charge for it, so we do the same for all our patients.
I didn't know that. Fantastic. What are your contraindications for artificial disc replacement?
It would be spondylolysis, spondylolisthesis, not degenerative listhesis though, if they still have healthy facets.
Okay.
You understand the difference? Yeah.
Yeah.
So, and facet joint arthritis.
And you know, I'm going to throw myself out there. I've had some surgeons across the sea tell me no because my facet arthritis is too bad, and some say that, you know, you've been one of the few that said, yeah, it shouldn't be an issue. Why do you think some surgeons still feel that, you know, a little bit of arthritis may be an indication or a contraindication?
It depends on how, I mean, I notice nowadays, since I spend a lot of time checking facet joints on MRIs, that a lot of radiologists are not so used to diagnose what's going on in the facet joints. They are very good at describing what happens to the nerves, whether they are under compression, this and that, but people haven't asked them frequently enough, what about the facet joints? So they're not so trained on judging them. That means I have one radiologist that I'll send pictures to if I'm in doubt. But normally I feel pretty confident with my judgment of the facet joints, and I use the Fujiyama classification. I think I still stay on that. I don't want to see signs of facet joint arthritis, but I think if things develop as one might think, we could be a little more tolerable when we have a viscoelastic prosthesis in the future. But who wants to be a guinea pig?
Sure. You know, I'm going to talk about some of the issues now. Two issues that a lot of our patients have post-op. One is SI joint problems. And, you know, we're trying to figure out if it's from the artificial disc replacement, whether it being an active L or pro disc, or and we've seen it all. People with M6s with SI joint pains, and it's becoming really common. And then, you know, we see some patients have fusion that don't have any issues with SI joint, and we know that, you know, when you fuse that L5S1, you're creating that body needs to move somewhere else, and we know there's not much movement. But what do you think are some of the causes for people with, you know, laxicity problems, or just the opposite in that area?
Well, this is really difficult. on one hand, there is a extremely strong promotion from the industry to treat a lot of facet joints. On the other hand, just sound thoughts say that primary facet joint problems are very rare, even if I fuse and others would hope it would be very common. That means that you have to be scrutinize yourself if you believe a patient has a sacroiliacal joint problem. And it's shown that after fusions, the loads on facet joints might increase. It's not shown if you maintain mobility. Even, and from my experience, I'd say that throughout these years, I've had 2 patients that has had developed or had persisting sacroiliacal pain after total disc replacement that also corresponded with blocks and things, so we can really believe that it was sacroiliacal pain, and they were also treated at our clinic with that. But if you compare that to the enormous number of patients that I've done, I think it's extremely rare, but it's much more frequent after fusions. I haven't seen it. Those 2 patients were totally 2-level mobile, so I haven't seen it yet on any of my hybrids, but that might depend on that. The hybrids are a little fewer.
So if you recommend somebody with a hybrid, fusing that, what is your best intention for them not to have issues at that level or at those SI joints?
Live a normal life. Within this, we have patients that doesn't dare to get rid of their pain in total. I mean, if some pain leaves them, there has to be something to hang up life on. And that is a problem. It's normally anxiety problems, one or the other. But if sacroiliacal joint pain would be very common, every woman that would have been pregnant would develop it.
Sure.
Because at that time they are extremely loose out of hormonic reasons to
Sure.
The pelvis, the ability to give birth to a baby. So I think you have to be very careful with that diagnosis. I think it's presently overdiagnosed, and there are reports coming of a lot of materials with SI joint fusions, whatever they have done to their spine earlier, but with not so very good results. So I think it's overdiagnosed presently.
I would agree. Do you guys in Sweden, are you guys on the curve of regenerative medicine as far as like you're doing PRP with your physiatrist or bone marrow aspirate, where we're taking concentrations from the iliac crest? Are you guys kind of evolving in that yet, or is it still kind of we're not sure it works?
You mean for stem cells or for bone transplants?
Well, not necessarily, but for regenerative, in the United States, and I don't think you guys are kind of using, but in the United States, we have a lot of physiatrists that use PRP. Obviously, we take the blood and take the protein-rich parts of the blood and inject it back into areas where there's issues. And we think it's, you're kind of taking a solution and making it more direct rather than your body trying to get blood into the area. We know blood obviously is kind of the precursor for healing, but that's what I was wondering if you guys have been, the one thing that people need to know about you, you've done probably more studies than any surgeon I've known, and fabulous studies they have been. And like I said, I wasn't sure if you're going that route, not to say you, but if you know anybody in Sweden doing that or studying that. No?
I think there's a high risk if somebody would start. Nobody has, as I'm aware of, started, but I think it would be very easy that they would be judged as a homeopathic treatment and
Sure.
would not be allowed to do it. Our medical system is extremely science-based, and we're not allowed to do a lot of dilly-dally that doesn't have a scientific proof.
We're kind of promoters of it here in the States, and I'll be honest with you, I kind of am. I work with some folks, and And I think it helps a lot of people. It doesn't help everybody. And it's hard to put that finger on why or why not. And, you know, that's why I think more studies, but we do have a lot of studies that are indicators that it does work. And it could be just a placebo effect as well. I mean, but, you know, I'm somewhat of a proponent. I've had my facets injected and I feel better afterwards. And you know, I think there's a use, but I wasn't sure where Sweden stands on it, but yeah, that's fair.
I think we are on that. We are more conservative, but soon as if science is done on it, which I like, then we will have results, solid proof result, where the direction to go, and I guess that is what would be needed for somebody to pick up that in Sweden.
True. Moving on, this is more for our patients that have had artificial disc replacement. How many artificial discs have you removed? And I want to go even further with this question with you is how many artificial discs have you removed and fused, and how many artificial discs have you refused and replaced with another artificial disc?
On all patients, I've removed 2. One was a charité, where the core went posteriorly to the spinal canal and slowly developed spinal stenosis. Took it away, made an ALIF. I have had one pro disc where the polyethylene luxated forward. I took that out, replaced it with a little higher disc, and got it probably better to the PLL because it was a Jewish guy, and but he did fine after that. Then I've had a couple of patients, not many, but a couple of patients for that have been treated in Germany or Norway and this and that, where I've actually exchanged the disc most of the time. There are a lot of brands that doesn't work either short or long term. One on another, I've done an ALIF on because during the process of the subluxation of the first disc, the facets broke down, but it's not a lot. It's few cases, but mostly I've replaced it with a mobile disc.
Okay. Fair enough.
And on the cases that I mentioned where that had metal disease, I left the discs in place because with no mobility, they don't produce any more nanoparticles, and they were good distance holders of disc height. So
this question is probably more aimed towards cervical, but what do you do to prevent? I know you let the viewers know you do not perform cervical at this point anymore. You're just basically a lower lumbar guy. But what do you do to prevent heterotopic ossification for patients? I mean, I know you've probably never had that happen, but if you ever, I mean, you've probably seen it in cervical. We all know that.
It depends. I think it's more frequent in the cervical, and it's both part of the surgical procedure in itself. If you leave bone flaps, bone substances, that you can reduce the risk. But my colleagues that does this, they also give acetylsilic acid to it's a close to NSAID to prevent it.
Okay. Do you do anything different that you would say to prevent scar tissue from occurring when you're doing your ADR?
We don't put anything extra in to prevent it, but we try to do a very reduced preparation, explore nothing more than we need to, and we always go extraperitoneally, of course, as you should, and then you don't create any scars within the peritoneal, in between the intestines. But the vascular surgeons know that as long as you've been in the retroperitoneal area, there is a risk of scar tissue late that might affect a ureter. And I had 2 patients with that. We found it before the kidney was injured, so we could put the pigtail up and dilate it, and then it was over. But since we need just half a kidney, the danger is that this could be silent, and the patient doesn't know until several years down the road that one kidney isn't working anymore. So you have to be very careful with the ureters.
Mm. What is your typical follow-up for your international patient? You know, they leave Sweden, you know, anywhere from 5 to 12 days, depending on the patient's, you know, concerns. How long will you follow them up for, and then how many X-rays will you ask for?
Well, I know that Sweden is a little remote, but in the ideal, it depends. People that travel through business, they have a tendency to plan their travel so they pass Sweden, and then I see them the same way as I do with Swedish patients after 3 months and 12 months. And at 3 months, I take the same type of X-rays that I do the day after surgery, just sideways and from front. And at 1 year, I take flexion extension pictures to judge that there is a nice mobility in the spine. And then everything below that, because some people have spent their last dimes on getting the surgery. They cannot fly out to see their surgeon. And I've had in-betweens where I met people when I've been in conferences in the States, or I've also had Australian patients that I met when I've been to Australia, but that is fairly infrequent. I try to do this. Some patients do their X-rays at home, and I Skype with them.
Sure. So let's talk a little bit about distraction pain, because it's one thing that a lot of our post-op patients have as well. You know, there's kind of a lot of numbers out there. I think it's anywhere from 30 days to 6 months that we have patients with distraction pain, some even, you know, up to a year. What do you think are the cause and effects why some patients have more than others? Do you think it's more a procedural basis that's causing these issues? You know, remember, I think when we first met, I asked you what distractors do you use, the Synthes distractors, and you said, yeah, that's the ones you use, because I understand those are the most delicate on the vertebral bodies when you go to distract to place that ADR. But what's your overview on distraction pain? Because we definitely...
You mean distraction of disc space?
Distraction of the disc space, obviously, when you're stretching those nerves back to place that disc back in there. Obviously, that's a load on the body that it can be very severe, especially if you're looking at 1, 2, or possibly even 3 levels.
There's 2 types of distraction pain. One is if you have a scarring around nerves, like a patient that have early gone through disc herniation surgery. They might have a scarring from where the disc herniation was, and 1 out of 7 of them will have a new sciatica because of my distraction. But that is a very, very good outcome of that, because between 3 and 5 weeks it's gone, and I treat them with gabapentin or something like that, and then it's gone, because nothing has happened to the nerve more than that it starts moving and stretching its adhesions. But those adhesions would resolve without having to do anything. And then you have the more frequent distraction pain that all patients might have. And that is a muscular one, because I make them suddenly taller. Not taller than they were when they were healthy, but taller than they've been for a long time. And these patients, as soon as you develop this diagnosis, you start moving, as I do, in dancing shoes on ice with bad light. You tend to tense all your muscles. First the beef, then your buttock, and then your hamstrings. That is a reflex of the pain. And patient doesn't come the week after they had this. They had it for a long time prior to treatment. And as you noticed, we try to address this already prior to surgery. So patients go through extensive program to stretch their backside muscles and pick it up in the abdomen instead to get as little as possible of that. And we start stretching muscles already at the wake-up department. Was that an answer?
Yeah.
Then, of course, why you might have two patients that have had the same problems for, let's say, 5 years, 2 discs. One of them has it more than the other, but that is how muscles are. They are not identical between different patients. You're differently prone to develop short muscles.
Let me ask you, what is your range of protocol on this? I'm just thinking of you. If you see a patient with a large herniation in the lumbar, say it's a L4, L5, or just one possible level, do you recommend a discectomy first?
If it's a one-sided sciatica, that is a major problem, and not a lot of low back pain, yes. Even if I see it's a bad disc, I would recommend a microdiscectomy. But if I see a big central herniation with a lot of low back pain and maybe some sciatica to both legs, then I think it's in vain to do a discectomy.
Fair enough. A surgeon told one of our patients post-op that he's young, he's 27 years old, and he said, will this disc last me, my lifetime? And his response was, it probably will. And he has a ZAC, so that's not, I don't think the concern is there. But he said that ossification probably would happen over time. And I'm not sure if I believe that or I agree that, but I guess what's your point of view for a patient? And I know you've done some younger patients as well. You had a few there when I was there. But, if you're doing a young patient, what are your theories behind what's going to happen long term?
Well, for once, the testing of prostheses, and especially the SAC, is so rigorous. So somebody counted and say that no wear signs will be seen in 400 years in a cleaning woman if she never rested. That means if you get 600 years, then there might be a wear problem. Nobody does. So that is for the prosthesis. And I think I've gone through this testing, as I always do when I pick up a prosthesis. I go thoroughly through also with friends that are engineers that it's well done. There's no fake testing, but it's high quality testing, so I can rely on it.
Sure.
But the other thing is what happens with the segment as people grow older. My experience since I've done this for long, and some patients I've had back to have flexion extension pictures with other prostheses because I'm on the 3rd year with SAC. And but Pro Discs and this and that. And with Pro Disc, for example, I had a couple of cases there that went mobile after 2 years checkup, but I haven't seen any added fusions after that. So if nothing happens in 2 years, my firm belief is then they stay mobile.
I guess, my question, my thinking is, if we're not placing a disc in there, because a ZAC, as we know, is 10 to 12 millimeters in height. So I think that's why ossification is almost impossible, even as we grow at a young age. So this patient's 27 and he makes it, say, to 85 years old. And we know that our bones will eventually form together and do all kinds of crazy things, and that you can't even imagine them. You've seen probably more x-rays of older people than anybody. But I guess that's what I'm kind of quite. If we're placing a disc, ossification should certainly almost not happen because you have so much of space in there. Now, if you didn't have a disc, over time, we all become bone on bone and fused. We know that, and everything kind of absorbs into each other. And most of the time, these patients don't have pain. But that's what I'm looking at is, do you think over time that the body would fuse itself, that fuse around that ZAC over a period of 50 or 60 years?
To be honest, of course, I don't know, but I can make a theoretical discussion. Bone formation is, in most cases, a reflection of an inflammatory response. If you're taking the full disc out, the local inflammation cools down. There is nothing, no substance left that has an inflammation, and that means that since most of the ossification is a late result of ongoing inflammation, I think that this might as well be just a cool area where nothing happens.
Yeah. Okay, how high will you put a ZAC? Will you go to L2, L3 and stop there? Will you be below there? What's your feelings on the motion at those levels?
I put it at L2, L3. It's very few patients that need a artificial disc replacement in L1, L2. I've done it a couple of times because of serious large central herniations, but none. That's also very rare condition in that level. So I haven't done it since I started with the SAC.
Yeah, we've had a few patients. I'll give you one patient that had a fusion. He actually had a X-lift. And that kind of sometimes makes sense, but we know there's issues there with the X-lift with some nerve issues. But he basically had a cyst that had to be removed, and the surgeon, did the X-lift. Probably should have never been done in the first place. Should have probably removed the cyst and waited to see what happens if the pain went away. But he had a fusion. The fusion didn't work. The fusion failed, and then the fusion failed because the surgeon only placed one rod, which was kind of strange, and we think that was part of the reason, just on one side. And then 2 years later, there was no fusion, so he had a disc put in at that level. And the surgeon that put it in at that level had a hard time because of the bone formation trying to happen. And I guess, would you have done something possibly different, maybe for someone else at that patient, maybe above or below that level, as a revision surgery? It's just kind of asking for your own personal opinion, what you would have done. So kind of reaffirm L2, L3 did not fuse a cage. I think the cage was actually way too small for that area, but I mean, we know X-lift, you only got so much disc height that you can kind of fit through there. What would you have done?
I would probably not consider total disc replacement after a failed fusion attempt. If the patient came to me, I would probably see to that the fusion got healed as thought.
So you would have tried to help the fusion along, maybe put a rod on the other side to kind of
new bone graft and probably also address the cyst from posterior.
Okay. What are your? I mean, obviously, companies come to you left and right probably to show them new technology. What's your best guess on technology that's going to change in 5 years, 10 years? I mean, we know that hopefully that FH Orthopedics is coming out with some different sizes. We're hearing. Maybe you can reconfirm that. I mean, obviously, I know you talk to them quite a bit. Is there anything else you see coming out that looks promising?
I think that we are at a trend change now, because a lot of us that are interested in total disc replacement have wanted viscoelastic processes for quite some time. There have been some failures down the line. We know about the Acromed prosthesis. There has been other failures. M6 also fails, but not as fast as the Acromed did. But we've still been in the need of it, or the desire to have viscoelastic processes, because it doesn't take a genius to realize that the viscoelastic processes more mimics a healthy disc than a loose mechanical one. Even if we have had very good results with the loose mechanic ones, they are not so physiological that we would want that. And that means that I think in 10 years, I don't think there is any mechanical processes anymore.
Okay. You think it'll all just be viscoelastic? Do you think
Yep.
it'll be a more patient-specific? You know, everything's patient-specific these days on a lot of these with these implants, meaning that they're doing 3D, visualization. Do you think anybody's going? You don't think that'll happen?
No, I don't think so, because what we're going to have is a tray with a lot of sizes and different angulations, end plate sizes, heights. But we don't know until we clean the disc out and distract and see what size would be sufficient for this patient. We cannot have a prosthesis made from the pre-op pictures where the vertebrae are hanging on to one another. We need to feel with our hands, how high was this from starters? And then we can say, bring me that to size. So I've been addressed also from a Swedish company that wanted to make individually manufactured discs for each patient, but I told them the same. If you can make it in 10 seconds, fine, but otherwise it's faster to take it from the tray.
Sure. And I would agree with that. I think this is the last question, and it just escaped my mind. What was it? And you have never done any dynamic stabilization?
I've done some dynasis in my early days, in the early 2000s. I've done some padding between spinal processes with like X-stop, diam, and things like that.
Sure. And then what about, do you think there's a future for facet type device implants where it can create motion with the facets? You know, there's Premia, which, that Israeli company, and they've been, using that one. What is the name of that thing? Which one I'm talking about there.
Is it Arcadia or no? No.
It's basically two screws and they kind of move back and forth.
There've been many of them. The first one I ran into in the late 90s, and obviously it's difficult to get it working since none of them had been a real hit. And on the other hand, when I've been addressed about it, I have had a hard time to find the indication. To put these screws in is as much trouble as putting pedicle screws in for a fusion.
Sure.
And in my mind, disc degeneration always develops before facet joint arthritis. So if the facets are so taken down by time and age, how can you leave the disc without seeing to that something happens here? And to make anterior surgery one day and then turn the patient and put new facet joints, it's a long way before we do that.
So this is my last final question. It did come through. So when we were at in Le Mans, and you spoke about 4 different types of spines in the curve, and how some are more better for ADR than others. Can you give me kind of the highlight of that conversation, and then roll that into your therapy based with Maria, because I know you and Maria are very proud of doing that because of your outcomes. And one thing I'll say when I'll mention this, and I don't remember if you remember that conversation we had with your patient who was the farmer, and I think he was probably in his mid 50s, and I was amazed, and I was almost I think I was almost not agreeing, because this patient was doing so incredibly well. I think he had a 2-level, and he was a farmer, and he went down and he touched his toes, and I think he was 2 months out, and I was like, there's no way this guy's 2 months. But then when he pulled up to show his shirt and he showed the incision, and I said, yeah, that incision looks about 6 weeks old. And remember I commented, well, he has a little belly on him, because you want me to get rid of mine and whatnot. And we kind of laughed about that. He goes, yeah, I've been eating good since I got out of surgery. I put a few pounds on. But I guess, I know you want to talk about that a little bit, because it's something that's completely off from most people I talk to. and you're very passionate about it. So I guess I kind of want to go about that conversation with the difference and how it's improved your patients.
First, we start out with different curves, as we have different ears. And that's nothing that neither Maria and I wants to change. We want people to get back to their natural curve. But what happens during long time with low back pain is that your lordosis increase, since you get very strong and very short in your spinal muscles. And to a certain extent, we want to normalize this, get people back to their natural curve prior to surgery, and that is to prevent distractive pain and to prevent unnecessary load on the facet joints. But then there are people that has a curve of a very sharp lordotic angle between the L5 vertebra and the sacrum, and they are, most of the cases, they already have developed facet joint arthritis because they hang on the facets. The exclusion from that is patients that also have a retrolisthesis of the L5, because they don't put the load on the facets even if they have a sharp angulation here. But that is with the mechanical processes, and you must believe that out of 24 years with discs, most of my time have been with mechanical prostheses. If I see a too sharp angulation here, even if the facets are okay, I would suppose a A-lift at that segment and a disc on the other one, where I can pick up all this angulation in my A-lift to prevent the mechanical disc from going into hyperlordosis and give leg problems from the facet joints. The SAC is a little game shifter because, first of all, it has lordosis built in. You can decide from 3 different degrees of lordosis, and it would counteract that the patient put all loads on the facet joints, since you can't tilt it over backwards as you can with a mechanical one. And so all these 4 steps is, if you take the extreme, so it's what I tell my patients, you got a duck ass. That means that you could put a teacup on their sacrum because it's horizontal. And to the other one that carries their sacrum right underneath them, they might have been like that all their life. And that I'm not the one to change it, but normally we realize that when they start doing the physics before. And I wouldn't put them into more lordosis than our God actually intended them to be. And I'll use as little lordosis prosthesis as possible. Was that an answer?
Yeah, I guess it was. And then, maybe just touch on, and you don't have to a point. I mean, if Maria's going to send us videos of your regimen a little bit, maybe just to give me a quick 2-minute discussion on the regimen and how it's helped, because you're the only surgeon that I know that has a pre-op program as well as a post-op program. Everybody has a post-op program, and some are more than others.
And we always try to learn our patients that to extend or get lordosis is a foul word, and that is because, are you still with me?
Yeah.
Are you there?
Yeah. You were talking, but your video wasn't going. You're back now. But I still heard you.
Yeah. So we tell our patients that whether they're going to have the best result from surgery like this, they're going to do most of the work themselves. That's why we start prior to surgery. After surgery, the only thing they have to do is keep extending their lumbar muscles so that they don't go into cramps. And as soon as they feel they can that because of wound pain, start using your straight abdominal muscles. And the precaution, we've learned then that's a foul word to put your back in extension because pain has put it there for a long time. But the special thing for the sac, since it's so rigid, I don't want them to make twists and turns between the hip and shoulders for the first 8 weeks.
Okay.
Are you there?
Yeah, I'm here. Your video stopped again. It might be your signal.
Hello?
Okay, I can still hear you. So if you want to continue, if there's something you forgot, you're back now.
How much did you get?
I think I got it all. I just didn't get you moving much. Your video froze, but the sound was still there.
Well, be as happy for that. Anyhow, we prevent them from doing rotations. That's nothing that I've prevented on mechanical prosthesis. But since this is a block, it relies on ingrowth from the end plates. I don't want them to make twists and turns between the shoulders and hips the first 8 weeks.
First 8 weeks.
Then 8 weeks.
Then after that, what do you do?
And then can parachute after that.
Really, parachute?
Pardon?
I said, really, parachute? I've parachuted before. It's,
Yeah, actually, I usually tell my patients at 3-month checkup that now you're free to parachute, and most people just look afraid.
Yeah.
But last week I had a mail from a patient that I did 2 months down the road, and she's doing fine. And she was obviously a parachuter. I didn't know, so because she wrote me and asked if she could start again.
There you go. You fulfilled her dream. She can get back to work.
Yeah.
I guess lastly, and let's just talk a little about, patients here would like to reach out to you. And we try to tell every patient that, if you're reaching out to Dr. Berg, please have, full intentions. If you like the video, and you're serious about going to Sweden, make sure you're serious about it. Don't waste the doctor's time, because we definitely have come across some patients that sent out, 5, 6, and we expect you to kind of look at it, but keep it to a glance. That's why we do these videos, is to really find the surgeons who you connect with the most. But I know you're doing holiday this summer. When's holiday for you?
Starts, I think, 1st of July or something like that.
And then how long will it last?
5 weeks. 5 weeks.
5
I'm
weeks.
A farmer. That's when I'm a farmer.
That's when you're back to the ranch.
Yeah.
And then Kenneth wants to know, do you get Swedish fish as treats? You get Swedish meatballs? I mean, is that what we get after our post-op food?
Actually, the restaurant at the hospital, they makes fish twice a week at least.
Okay. I wasn't sure. Do you know what Swedish fish are, the little red candies?
No, I didn't. I thought you meant real fish.
I didn't think that was we have a candy here that's like a red gummy thing that's been around forever. My father loved them, and they were called Swedish fish. But of course,
is it like a jelly thing?
Yeah, red jelly thing. Yeah.
Okay. Then I know. I had heard it. I thought he meant our soul and this and that.
No.
Our hearing.
We'll bring you a box if we come in September. What is the best way to get in touch with you? And then what would you request them to send you as well? Tell them the whole thing, what you want to see from, that way you're not, repeating yourself.
Description of history, description of pain, and what causes the pain to increase and to decrease, and some exams from MRI preferably.
And you also want X-ray?
If they have it, yeah. But the MRIs are the most important.
The one thing that we do push, and you may get it as well, and I still think it may help, is DEXA scans, but we know there's some inaccuracies with some DEXA scans. So you may get that as well, just from people seeing some of our other things. When we try to have them, when we try to prepare them the most, X-rays, ways of life, whether they smoke or not. Will you perform surgery on somebody that is a smoker?
No.
Good. We tell all of our patients, listen, quit. No sense even being in the program if you are going to smoke. So
And we demand from all our surgery that they stay off smoking 6 weeks. And I explain to my patients that those 6 weeks are the beginning of the rest of their life without cigarettes.
Sure, I completely agree. And then what's the best way to get in touch with you as far as your email?
My mail address, I guess.
Do you want to let them know what it is?
Yeah, it's all small letters. Svante, it's an E at the end, even if you don't pronounce it. We do. And then .berg @spinecenter.se.
And then you can also find that at your website. I think it's www.spinecenter.se, correct?
Yeah.
That information. And then typically the time, how long does it take you to respond? That way they can be patient as well.
Little depending on what weekday and so on. As you probably noticed, sometimes I'm answer within 2 minutes, and sometimes it takes 3 days.
Sure. I just want people to know that, and usually we tell everybody, give everybody at least a week, because there may be certain circumstances. You may be busy, you may be with the family, and we definitely always try to ask for at least a week. Is there anything else you wanted to talk about before we go?
My mission is to have people with this type of problem never to give up, because most of it is curable.
Fantastic. Anything else?
Welcome.
Welcome to Sweden. All right, folks, I'm going to end this video, and I'm going to talk with Dr. Berg a little bit afterwards. Thank you so much, Dr. Berg, for doing that. We really appreciate it.